We are live now, ma'am.
Thank you. Good evening, everyone. A warm welcome to one and all for this 12th episode of AKSHARAM series, our pet project by our president, Dr. Vijaya. It has been an extremely beautiful journey for these past 12 months, inviting speakers from all over the country, eminent teachers who have been like professors, examiners, and who has been the real role model for all the students, talking about one particular topic and giving a complete insight about the entire topic. Many PGs have given us a very good feedback, including consultants have given a feedback that they have benefited by this Aksharam episodes. This evening, we're going to talk about abnormal uterine bleeding. We know this is 60 to 70% of our major gynec practice is benign gynecological practice is abnormal uterine bleeding. And definitely it also forms the daily bread and butter of our clinical practice. And now we are going to talk about A to Z of AUB this session. Welcome address. I request our President Vijaya Madam to deliver the welcome address. Vijaya Madam is a professor in HOD at ESI Medical College, KK Nagar, Chennai, former director of IOG, Madras Medical College, Chennai. She is special interest in high-risk pregnancy, infertility, and laparoscopic surgeries. Madam is a dynamic president. We had lots of fun and we did a lot of academic work, clinical work during her tenure as a president of Oxy. She has a lot of publication awards to her credit. Over to you, Vijaya Madam.
Thank you, Karpagam, for this lovely introduction of me. And good evening, everyone. At the outset, I would like to thank everyone for all the postgraduates and the young consultants for being here in the evening. And every month, spending 2 hours of knowledge sharing session. And we have started this webinar 11 months back. And every month we used to think who should talk and what is the topic of interest for the PG, especially the exam going topic, and also the points has to be clarified, whatever doubts they have. So this is a real task actually. Every month we have to select a good teacher. That is because throughout India we know so many medical colleges, so many professors and lots of postgraduate institutions. And I see to it I handpick the best. So on this regard, Kiran ma'am is always with me from the beginning. And my sincere thanks to Kiran ma'am for supportive, and she always encourages me and she gives such a good words, and we feel really happy at the end of the session. And thank you, Kiran ma'am, for being here. And also I would like to thank my Oxy, all the EC members for being supportive to this, and also my dear postgraduates. And on this note, we'll start the session with our prayer song. And yeah.
Good evening, Vijaya.
Yeah.
Hi.
Starting. Okay.
Okay. Hi, Karpagam.
Hi, madam.
Okay.
We always start our sessions with lighting of the lamp.
Pleasant music. Felt like listening for a long time.
Thank you. Now we always start our sessions with a prayer to Ma Saraswati, because without God's blessings, nothing is possible. And definitely lighting the lamp, dispelling the darkness, and throwing light in everyone's life is most important with the divine blessings.
Yeah.
I welcome our Secretary Madam, Dr. Geeta Lakshmi, to deliver the Oxy prayer. Geeta Lakshmi Madam is Associate Professor at Government RSRM Hospital, Stanley Medical College. Madam is a PG and a UG teacher for many, many, many years. She was a Secretary of Oxy, member of Chennai Menopause Society, SOFSI and ISOPAR. She has presented papers in various national and international conferences on areas of interest, high-risk pregnancy, adolescent health programs, and medical education. So actually, medical education is everybody's interest throughout our Oxy. So we all are very happy to have all our eminent faculty here. Geeta Lakshmi Madam, over to you for Oxy prayer.
Oh, thank you, Karpagam. First of all, very good evening to everybody. Welcome, Kiran Madam and Dr. Malati Madam. Nice to have you here for the last episode of our Aksharam. And with the blessings of the Almighty, we shall start the last episode. So I will go on with the Oxy prayer. Thank you, God. In humility, we gather. In gratitude, we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and mom reborn, the courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you.
Thank you, Geeta Lakshmi Madam.
Thank you.
Next slide, Sahiti.
Pragiti?
Yeah. Now, our President Madam will welcome Chairperson of Medical Education of Committee of Foxy, Dr. Kiran Pandey.
Kiran Pandey, as I said, one of my best friend and beautiful mentor and a guide for this medical education committee CME webinar and every month for the students. And Madam was so enthusiastic and behind us and encouraging us in all our activities. And she is the current chairperson of the medical education committee Foxy, and she's a professor and HOD of Department of OBG, Kanpur. And she's the past president of COGS and IMA and president UP chapter AOGI and 2024 to 26. And now she's the current president of the COGS Kanpur Menopausal Society. And Madam has a lot of research achievements and awards. And moreover, more than that, she's a very simple person and always very, very enthusiastic and clear whenever we ask for any help. And over to you, Kiran, and we welcome you.
Thank you, Dr. Vijaya. Thank you. Thank you for very kind words. It's a mutual admiration, I would say. Even I mean, I feel lucky and privileged to be a part of all your webinars throughout the year. And really, I mean, this is I mean, I hope it is not the last webinar of, it might be of this year, but the programs should continue because they are very important and chosen ones for the postgraduates for their coming exams. And actually I joined with this feeling and passion for the postgraduate teaching, that it's very important for their exam, to relieve their examination pressure and keep them get the mastery of the subject. And I'm very feeling always good, like you select very practical and important topics for examination purpose. Like today's topic is also wonderful, AUB. I mean, maybe a postgraduate, maybe a young practitioner, maybe a mature practitioner, everyone has to deal with AUB as a person, as a patient, and even everybody. this covers whole lifespan of a woman. So it's such an important topic, and so much of a variation, so much of new things have come up, so much the management changes have occurred. There was a stage when only people used to think of hysterectomy, but now many of the minimally invasive surgeries have also come, besides the revolutionary changes into the medical management, even the classification which has changed. So it's very important for postgraduates to go through each and every step of it, and they will have to deal with it in the exam, in the practical life. So I'm really congratulate you, Dr. Vijaya, Dr. Karpa Kambal, Madam Dr. Geeta Lakshmi, and our esteemed speaker, that they have selected this topic, and they will, I'm sure and I'm very confident the students will be benefited. Throughout, they have been, number has been increasing. So it's a very,
Kindly mute others, no, ma.
Yes, ma'am. Yes.
Mute others, no, ma.
it's okay, Karpa. And I mean, I still remember, Karpa, that you came to the Kanpur and we had a very nice time. We missed Vijaya, but it was a wonderful show. And I mean, everybody liked it, and it was a wonderful time we spent together. And come sometime
Yeah,
again
sure.
to the Kanpur, and Dr. Vijaya, I will also invite you.
Another
Whenever
good
you
day.
feel like coming, just let us know. We'll design some program for you and do it.
Madam,
Okay.
we will miss you if we don't continue this program.
So that's what you have to continue, and the Foxy
Yeah.
has to continue medical education. And I am there for this. I mean, we are also starting. I hope you know, the Dr. Sunita Tendulwarkar is also very keen to start a PG program. So we are starting a PG program of in. Planning, because time has become less, but still all covering almost all states, 2 or 3 per month. We will be starting and launching in the April, in the month of in the April month in the Pune, and then we'll also come to the Karnataka, Tamil Nadu, Madhya Pradesh, everywhere. So PG programs are very, very important, and I would request all your PGs also to join those programs also. They are both that designed for the exam and decrease the examination pressure.
Yes, ma'am.
So now, without wasting time, I hope your speaker is already there, and students will have a very nice time learning project. So thank you very much,
Thank you,
and all the
madam.
best. Thank you. All the best.
Now we'll go ahead with the teaching session. Our President Madam will introduce Dr. Malati.
Malati, CV is there?
Yes.
Malati is one of my best friend, I should say, and we became friends only through examiners. Both of our examiners, internal and external, in lot of the examinations in Hyderabad and in Chennai, in IOG, in KGH. She has been there for undergraduate and postgraduate examiner, and you should see her bombarding the students with questions, and I am the savior for them. I say, Malti, go slow, go slow. They are tense like that. We used to have real fun during the examination. And you can see her CV. She was the master trainer of Telangana State in almost 12 programs, and BMONG trainer, post-abortal contraception, Dakshata, say, child sexual abuse, maternal near miss, and death audit. And you can see the examinership, UG/PG examiner, medical education unit, Osmania Medical College, guest speaker in all of the state, national, ICMR projects, and she has got a lot of chapters in updates in OBGYN, and she has got the poster prize Mastering 5 Senses versus Technology, Foxy e-poster slogan, International Women's Day Award, Obstetric Drills Foxy 2024, that is recent. She has secured the second position. Areas of interest is quality of care in maternal health, and she is 2022 to 2028. She is a member of ART Surrogacy Committee, Telangana. So next time I will give you ART topic, Malti. So
Sure.
welcome to Chennai on webinar, and over to you and to the students.
Thank you so much. I'll not waste any minute. I'll just go to the topic direct. And before I could start the topic, as rightly said by all of you, it runs in all the age groups, right from puberty to perimenopause, postmenopausal age group. The minute Dr. Vijaya had given me this topic, I was just concentrating how many women would be coming to me in the corporate, in the private clinic, and in the public. It was so surprising. 25 women I had seen in the span of 1 month from the time you have given the topic, right from pubertal age to the postmenopausal. So I can just say the incidence and prevalence is so high. That means every UG and PG is likely to get a case of AUB, a long case that took. So that's the thing. And AUB is an important contributing factor for infertility also. And most important is, like a senior practitioner, as Madam just now told, they are coming for second opinion. Somebody says a hysterectomy because of the awareness to conserve the uterus or the spare the uterus. Now they're coming to seniors like Vijaya and me for a second opinion. So giving a second opinion on conserving the uterus, the challenge, there is a medical legal challenge not to miss out on malignancy. So whenever we say there is a medical management coming up for AUB, the important point message here is not to miss out on malignancy, and the woman should be compliant for a follow-up. With this introduction, I would directly go into the topic. Now, may I have the next slide? Yes. See, this slide, I would like to say that define the abnormal uterine bleeding. This is the latest definition. And if I look at the definitions, I have put up normal on one side, abnormal on the other side. See, coming to the frequency, earlier the definition was 21 and 35. Now it has been changed to 34 and 38. The duration, earlier there was a little confusion. Some of the textbooks still keep telling 2 to 5 days. But now we need to change the definition as per the new latest guidelines, and now it is 2 to 8 days. The quantity, it is the same which was defined earlier, 5 to 80 ml. More than 80 ml is abnormal. And this is a common question we ask when we are taking a menstrual history. Regular, will you get a regular cycle? But this is something difficult to answer, I felt, because they should have maintained a menstrual calendar of at least 6 months to know what is her longest cycle and what is the shortest cycle. And if it stays within 9 days, then only it is regular. So probably we get a reply from most of the women when we ask, are you getting regularly? They say yes. Without of much of the thought of calculation on this long and short, probably if you have to define it correctly, we'll have to maintain a menstrual calendar of 6 months to know what is our longest cycle, what is the shortest cycle, to answer this query. So the factors which they have taken into consideration to define is the frequency, duration, blood loss, the length of the cycle, that is the regularity. These are the 4 parameters to say the regular or abnormal. But NICE has taken a different definition, which is really, I feel it's important, because it says whatever is the frequency, regularity, duration, if it is affecting her physical, social, and mental health, that is the quality of care or quality of life. What do I mean by physical? Say all the symptoms of anemia, all the general weaknesses, not able to carry on the work, the fatigue, all that is the physical. If that amount of symptom is there, that means it is heavy menstrual bleed or abnormal bleed. Social, not able to attend the function, not able to go to the office, school, or the hospital or institution office, that is the social, where she's burying herself from going and attending certain social activities. If it is really hurting her mentally, when will I get a cycle? Should I book a ticket to a pilgrimage center? Should I accept this or not? That is causing a kind of mental stress, and also a mental stress with the sexual activity. So all these three is important. Quality of life affecting her, the menstrual cycle, is taken by NICE as a guideline to say that is abnormal. Next, please. So this is another theoretical question we need to understand about the pathogenesis of heavy menstrual bleeding? So simple to remember. If you get a theory question, you need to answer this. So it depends. The first point is the fibrinolytic pathway. It is controlled by progesterone. So that's why we use progestogen as one of the important medical management in heavy menstrual bleeding. So how does the progestogen help or is a causative factor for the heavy menstrual bleeding? So remember three things here in this slide. This is tissue plasminogen activator. They found that women with complaining of heavy menstrual bleeding, the tissue plasminogen activator levels are more than the inhibitor. This is controlled by progestogen. So this is one theory. And the second theory is the increase of the vasodilator prostaglandin, again controlled by progestogen. This is how the NSAIDs have come into play in the medical management. The third is the pro-inflammatory cytokines. Again, it is being controlled by progestogen. So progestogen is the one which is the medical management for heavy menstrual bleed, because this all the three pathways which I have mentioned now is controlled by progestogen. Next slide, please. Yes. Now, Madam was mentioning about the FIGO classification. Yes, we have FIGO 1 and FIGO 2 systems. In FIGO 1, bleeding patterns have been described. So, in this, they have simplified further by saying that whether it is a predictable cyclical, that means the woman knows when she is going to get her next cycle. When I know when I'm going to likely to get my next cycle, that is predictable. When the woman says I am unable to predict when I'm going to get my next cycle or when I'm going to bleed, that is acyclical or non-predictable. So it is just divided into predictable and non-predictable. Under predictable, again they have subdivided into only two categories, that is heavy menstrual bleed and intermenstrual bleed. The same thing in both predictable group and the non-predictable group. So we always say that there is a provisional diagnosis for everything. So in case of an AUB, the provisional diagnosis is based on the menstrual history. If the woman says she has a heavy menstrual bleeding and she's able to predict when she's likely to get the cycle, then the provisional diagnosis, the probable cause for this heavy menstrual predictable cyclical bleed could be adenomyosis, leiomyoma of submucous variety, coagulation defects, or endometrium could be the cause. In the palm coin, these are the causes. If the woman says she has an intermenstrual bleed and it is cyclical, probably it is a polyp. One caution over here: a benign polyp can present cyclically, but malignant polyp, there can be intermenstrual bleeding which can be acyclical. So do not go by the impression that intermenstrual bleeding cyclical is always because of a benign polyp. It can be a malignant polyp when it is acyclical with intermenstrual bleed. Coming to non-predictable, that means she doesn't know when she's going to get the next cycle. Heavy menstrual bleed, it is mostly M malignancy. Intermenstrual bleed, acyclical, is most of the time it is ovulatory dysfunction. So this is the simplification of FIGO 1 system based on the bleeding pattern. There are few new changes when compared to the past. So in the past, the amenorrhea was not included under frequency. Now that is being included. With regarding to the regularity, I told you this is little difficult to answer unless the woman maintains a menstrual calendar. The difference between a long and short cycle, when it is falling within 1 week to 9 days, then only it is regular. The duration, as already discussed, it is extended up to 8 days. But remember one thing, most of the menstrual blood loss is said to be on the second and the third day. But as she goes on to the fourth, fifth, sixth, seventh day, the amount of blood loss should be less. Then only it is normal. Just don't go by this 8 days number. Go by the quantity also. So second and third day, the flow is heavier. As the days pass on, it tapers. And as I said, regarding the volume, though it is said more than 80 ml is heavy menstrual bleed, it has included NICE, that is the quality of life, into consideration. That means when we are eliciting a menstrual history, it is important for us to understand, to ask on these three components: physical, social, and mental, that is the quality of life, in our questionnaire when we are managing a case of AUB. Intermenstrual bleed, both cyclical and acyclical, has been introduced into the new system. These are the new changes in the FIGO system 1. Now let's go to the FIGO system 2. Please click it. I need a complete slide. Yeah, complete. Yes, thank you. No, previous. Yeah. So FIGO 2 system classification, it talks about the palm and the coin, which we are very familiar with. Palm stands for the structural, coin stands for the non-structural. But some new inclusions have been done in FIGO 2 system also. One of them is the category 3 is now included. The type 3 is included in under submucous. 0, 1 and 2. They stopped submucous at the level of 0, 1 and 2. But now the type 3, where there is a contact with the, earlier it was categorized as intramural, now they have put it under submucous. Why? Because all 0, 1, 2, 3 are symptomatic and they can be managed hysteroscopically. That's why they have clubbed all this under submucous variety. And then about the stalk diameter also has been, ultrasound and MRI are able to give us more information about the stalk diameter. And the new changes, coming to the new changes about the palm coin, earlier AUBC medication was included, that is anticoagulants, anti-epileptics were included under AUBC coagulation defects, but they now shifted all the medication into iatrogenic, because we know medication is something we can reverse and it is iatrogenic. So they shifted medication completely from C to I group. And now I stands for all these medication, anticoagulants and drugs which interfere with ovulation. So medication comes under iatrogenic, including your IUCD and all that. AUBO, drugs interfering with ovulation, is not included in O, and that has been shifted to I. So basically, iatrogenic has all the medications which are responsible for the bleeding. And N, earlier they put N as not yet classified. Now they think we are in a position to classify, and now they put niche and isthmusal following a C-section, the continuous spotting and bleed following a normal menstrual cycle under this, and they have changed from not yet classified to not otherwise classified. Next, please. Yeah, this is another extension by FIGO. They have defined the category of ovulatory disorders into type 1, 2, 3, and 4. And the fourth group has exclusively PCO. Next, please. Now, coming to the history, as I said, we'll have to have a provisional diagnosis. So, history, they say it's very, very important for any case, more so for an AUB case, in a pubertal age. The two important causes in the pubertal age is O, that is ovulatory dysfunction, the other is coagulation. So how do we differentiate both of them based on the history? In the AUBC, that is the coagulation, heavy menstrual bleed since menarche. If the girl says since the time of menarche she has a heavy menstrual bleed, then you think it could be because of the coagulation problem. In the O variety, that is ovulatory dysfunction, the pattern of bleeding would be like a heavy menstrual, infrequent cycles, and then that means more than 34 days and then 38 days, and then the painless prolonged bleeding. These are the patterns we see in the ovulatory. When the endometrium is exposed to low estrogen, she will have intermenstrual bleed or a prolonged spotting. If the girl says that she bleeds once in 2 or 3 months and followed by prolonged spotting, or it is just a small bleed, that means the endometrium, the estrogen level is very low. This adolescent girl is much safer than the girl who says there is an amenorrhea followed by heavy menstrual bleed, because the endometrium is exposed to high estrogen and there is a chance of endometrial hyperplasia, atypia, and endometrial cancers in a very, very young age of PCO, as early as 24 to 28. So, this history is important. So, if they complain of little bleeding after a period of amenorrhea, then she is at least safe in one sense that she's like unlikely to have hyperplasia and malignancy. The one who says heavy menstrual bleeding, earlier we used to call this as metropathy hemorrhagica, the girl with this kind of pattern, she is at more risk of endometrial cancer. This is one thing we'll have to pay an attention in the history. Next slide, please. Coming to the, I just clubbed reproductive and perimenopausal because the etiological causes are the same, because they are sexually active in this age group. So sexually transmitted infection, pregnancy, benign to malignant tuberculosis, and all this anovulation in the perimenopausal. So these are the main causes of AUB in this age group. But one of the most important thing is ruling of the pregnancy, because I've seen women coming with who I was sterilized, underwent tubectomy. In the consent form also, we write there is a mention of 0.5 to 1% of failure following its tubectomy. But somehow the name is permanent method of sterilization. So they think that they can never become pregnant after a tubectomy. So there was a lady who was a Paris, 35 years, and she had come with pain, chronic pelvic pain, and spotting followed by bleeding, heavy bleeding, spotting, something like that. A bimanual pelvic examination has revealed a mass in the pouch of Douglas and a mass, TO mass, and it was thought to be like a chronic PID. On laparotomy, there were very dense adhesions and the products of conception. It was a case of chronic ectopic. So here my message is always rule out pregnancy. Even if the woman says she had undergone a tubectomy, rule out pregnancy. One of the investigations which is a must in a case of AUB, I feel, is either a urine pregnancy test or a serum beta HCG, because we cannot falter on this, and the management is entirely different, because palm coin, it says it is non-gestational, so pregnancy is not a part of the palm coin classification. This has to be excluded by us, and we had one or two incidences where we thought it was a case of leiomyoma, and it was a case ultimately proved to be a case of choriocarcinoma. So I'll be discussing those cases. So ruling out pregnancy, including beta HCG or a simple urine pregnancy test, is a must in all cases of AUB, whether she's tubectomized or not, in all age groups, including pubertal age, because marriage is not a bar. Marriage is not required for a pregnancy. It is only a sexual relation. Next slide, please. So coming to the menstrual history, we all know that we start off with this, but the students should understand why we ask for the age of menarche. The age of menarche, if early, nowadays we are seeing that it has been from 13 to 12, 12 to 10, now even 9.5 years the girls are attaining menarche. So early menarche is said to be one of the important risk factors for endometrial cancer. So age of menarche, please make a mention, and when it is at an earlier age like 9 and 10, just highlight it and keep it, highlight and see, and you correlate whether she has any more risk factors for endometrial cancer. All this we know what to do, but Another important point I would like to stress here is the change of pattern. Listen to the history, listen to what she's trying to tell. Earlier, I used to bleed for 3 days. Now we know the it is only abnormal uterine bleeding is more than 8 days. But if she tells you that earlier I used to bleed for 3 days and I used to use only 4 pads, but now I bleed for 5 days and I use 10 pads, that is a change of pattern. Just don't stick on to that definition of more than 8 days. So, what I mean to say is understand and try to understand and listen to the history and highlight this point. Change of pattern. We had women who said earlier she used to bleed only for 3 days. Now it just got prolonged by 2 more extra days, and that is the worry she has. Why it has extended to 5 days? Never she had bleeding for 5 days. So that is the change of pattern, and she's concerned and she wants to know if anything is wrong with her. So please highlight this point. And then intermenstrual bleeding, whether it's cyclical or acyclical. Postcoital bleeding, only if she's sexually active, she can give you this history. We had a couple of women who were not sexually active. They have presented to us with frequent, in a month, she got 3 times a cycle. In a month, she got two cycles in this month. But they were diagnosed with to be having carcinoma cervix. So restrict this history only if she's sexually active. So ask the woman whether she's sexually active or she's not, and highlight this point: active, not active. And others we have already discussed. And as I said, in the menstrual history, start including the quality of life, the nice definition on the physical, social, and the mental status. These are the extra points I think we'll have to highlight in our menstrual history. Next, please. Next. Yeah, obstetric history. Again, why should we include this in the obstetric history? We only directly go with the number of living children, type of deliveries, and all that. But I feel we'll have to include the treatment for infertility. Somebody taking a treatment for infertility for PCO, again, she stands a risk for endometrial cancer. So, nulliparity and treatment for infertility highlight if this point is positive in that particular case. Age of marriage. Somebody says, I got married at 13 years and I was sexually active from 13 years of age. Highlight this point because that is a pointer for carcinoma cervix. If somebody says, I married at the age of 15 and my first child was at the age of 18 or 19, highlight this point. Again, it is a pointer that she's at high risk for cancer cervix. Multiparity, we know the importance. Abortion, last childbirth, and contraception. The relation with contraception is whether she had used, and if she had used hormonal contraception, whether she had any problems with that. Because we had seen 3 or 4 cases landing up with venous thromboembolism, cerebral stroke, uncontrollable hypertension, for which reason they had to discontinue cholelithiasis, and they had to discontinue. So the woman, unless you ask, they will not tell you. So these are the, because most of the medical management of AUB would be hormones. So before you start any hormones, this history of using of the contraception, and also any problems or side effects she has faced in the past, make a note and highlight these points. Next, please. Yeah, here I'm just trying to emphasize in the history, whenever you find any of these, now BMI, not the weight, a gynecological case, an antenatal case, it's always a BMI. Highlight if the BMI is more than 35. Highlight if she is giving a history of diabetes and hypertension, PCO, a prolonged amenorrhea, and a positive family history. Any of these, if you find in the history, please make a highlight them. And these women should be managed in a different manner, not in the routine way. Next, please. Family history, very important. because tuberculosis, this is one question we ask: what is the pattern of bleeding the woman has when she is suffering with the genital tuberculosis? So answer would be a heavy menstrual bleed. Why heavy menstrual bleed in the beginning? Because of the tubercles and surface, there is endometritis. Acute endometritis, tubercles, is the cause for the heavy menstrual bleed, followed by scanty flow. Why there is a scanty flow following a heavy menstrual bleed? Because now the superficial layer have been attacked in the heavy menstrual phase. Now it is the basal layer which gets affected with the tubercle bacilli, and there is a destruction of the basal layer. Hence, the regeneration does not happen. There is a scanty flow. Why amenorrhea follows? When the entire basal layer gets destroyed and there is a synechial formation, they present with amenorrhea. And one more important thing is, when you give them withdrawal progestin, they do not get a withdrawal bleed. So this is the pattern of bleeding pattern in a case of genital tuberculosis. And this is a question we ask: what is the pattern of menstrual history you can have when the woman has a genital tuberculosis? Family history, as we said, coagulation disorders can be inherited, autosomal dominant and resistant. And then most important would be the Lynch syndrome. We have started asking now what are the genes which are responsible for Lynch syndrome? So remember these genes: mutation in MMR gene is responsible for colon cancer, ovarian endometrium; mutation in BRCA1 and 2 responsible for breast and ovarian; and for the endometrium, breast and thyroid, it is the mutation in P53, MSH, and the pole mutation. These are the three responsible for endometrium, breast, and thyroid. We started asking because now immunohistochemistry has become a part of our investigation. In the exam, we are asking you about this responsible genes which are likely to be mutated in these particular syndromes and these particular cancers. Next. No, I have a question there. Please, next, previous slide. Previous slide. Yes. Can one of the student answer which type of endometrial cancer is strongly associated with positive family history? One of the students, can he or she unmute and answer? Which type of endometrial cancer is strongly associated with a positive family history?
Type 2.
Type 2. So it is type 1 endometrial cancer which is strongly associated with the positive family history and also with high level of estrogen. Estrogen dependent. Type 1 is associated with positive family history and it is estrogen dependent, whereas type 2 is estrogen independent and carries a poor prognosis. So, with the positive family history, you can think of type 1, and these are estrogen dependent. Thank you for responding and answering. Next. Next slide. Yeah, in the general and physical examination, we always go with all these structures, breast, all this. But here I would like to emphasize, don't forget to palpate the supraclavicular area. We know that lymph nodes can be positive here. So this is one area not to be neglected. And then in the diet, its relation with a case of AUB, high consumption of animal fat. We asked about the mixed diet and all that, but also ask a question on how many servings per week she takes the animal fat, because endometrial cancer is said to be associated with high consumption of animal fat. And we know the importance of loss of appetite and early satiety in all the malignancies and tuberculosis. Another important thing I want you all to include in your questionnaire, in your history taking, is whether she has undergone any time the cervical cancer screening or whether she had a vaccination for cancer cervix prevention. So include this important questionnaire. And if she says, yes, I had a cervical screening test, ask her to show the report and see when it was done and what was the result of that screening test. And as I said, now the medications, all this has come into the iatrogenic category. These medications go into the iatrogenic category. Yes, next, please. This is see and palpate. See what to see and what to palpate. See, when you are doing a per speculum examination, what you see is when you see a friable growth, you see a friable growth and it bleeds on touch, it simply tells you it is a cancer cervix exophytic growth. When you see an ulcer on the cervix and it bleeds on touch and feel for the induration, these three features again tells you that you're dealing with a cancer cervix. Endophytic growth, it is a barrel shaped cervix and it is stony hard in consistency. So just seeing is not enough. Palpation, bimanual pelvic examination, we mostly give importance to the uterus size, mobility, anteversion, retroversion, flexion, and the fornices, but we pay less attention to palpating the cervix. So of late I have seen the cervix in one lady. She had been complaining of an abnormal persistent vaginal discharge, but they have not noticed she had an endophytic growth. This was missed on several of the bimanual pelvic examinations, and it was a classical barrel shaped cervix with a stony hard consistency. So always palpate the cervix and then go to the uterus. This is something which not to be missed out. And can any one of the students answer this query? Which type of infection of the cervix can cause bleeding on touch? Can anybody respond to this question? Is it difficult?
HPV.
HPV, you think it is the chlamydia. So whenever the cervix bleeds on touch, see, in Western world, they screen for gonorrhea and chlamydia even before they insert an IUCD. But in our training programs, we tell we do not have the screening methods in our country. So we teach them the features. A beefy looking red color cervix which bleeds on touch. It is a feature of chlamydial infection. So remember, it is a chlamydial infection which can bleed on touch and it's beefy red cervix. And about the categories, coming to the topic about the thank you for answering the question. Uh, we have three varieties. Acute. In the exam, you'll have to write whether you're dealing with an acute AUB. Definitely, acute AUB case will not be kept for you. It's most of the time it's a chronic. Chronic would be like more than 6 months history of more than 6 months, and at times we to the emergency room we find cases coming with acute on chronic AUB. So in the exam, mostly it is the chronic AUB cases which are kept. Next slide, please. Yeah. I have a question over there. Mention two causes for a barrel-shaped cervix. One we have already have here. Already we have one here. Yeah, please. Already we have one answer here. Is it difficult?
Also type in the chat box.
Yeah, somebody has to read out because I can't do both. Sorry.
Okay, yeah, no problem. What is the causes?
For barrel-shaped cervix, because it's important finding, gives you a clue.
Endocervical
Endocervical.
carcinoma, someone
Yes,
has said.
yes, that's
What is the
what we
next
have
one?
already told here. Endocervical.
One?
One answer already revealed here. Another one, very good. One you have already related here, endocervical cancer. The other one, the other one is cervical pregnancy. We had 4 to 5 cases of cervical pregnancy. This is one condition where the pregnancy is below the internal os and it is like a balloon shaped cervix, barrel shape or balloon shaped cervix, and painless. She gives a history of painless bleed. So this is the second condition. Is so cervix deserves to be felt. That is what I'm trying to tell you. Next slide. Yeah. Complete slide. I need a complete one. Yeah. So pictorial blood assessment chart. I know that this everybody knows, and it is given in most of the books. And according to this, if the points it's more than 100, then we label it as heavy menstrual bleed. But when do you advise a pictorial blood assessment chart? When do you use it practically? Can somebody answer? Can somebody answer? When do you really ask the woman to use this pictorial blood assessment chart?
If the patient is not able to explain
Okay.
how much bleeding she is having.
Okay. Okay. Thank you. Thank you. So, what I would suggest is whenever some of them are little fussy, I can say, or we are not able to understand the problem because there is no anemia, no features of anemia. When you get a CBP done, quantify. So whenever a CBP is done, we find that there is no anemia. It's 11 grams, 12 grams. And but she says she is having some change in the menstrual pattern. She's not very happy. So when there is a discrepancy or you're not able to get convinced between the history and her clinical features, you're not finding anything. So you ask them to plot this to see whether it is how much amount she is losing, so that you can get convinced or you will be in a position to convince. So there is a discrepancy between the clinical features and the history. That is one. And when do you advise? When you put her on a medical management. Whenever you put them on a medical management, you look for the effectiveness of the treatment. So at that point of time, then you ask her to start plotting first month of the treatment, second month of the treatment, third month of the treatment. So for monitoring the outcome of the treatment, this would be a better tool rather than anything else. So in practice, you use them for these two purposes. Now in one of the exams recently, DNB exam, the student was asked, how do you assess heavy menstrual bleed? Apart from that 80 ml, difficult, no? 80 ml and all that is difficult to measure. So, how do you? Are there any parameters to say that she has a heavy menstrual bleed? So, the textbook is giving you this definition. I mean, these criteria, not definition, these criteria. So, changing of the pads every 3 hours, more than 20 pads in one cycle, needs extra protection in the night. That's what the woman understands. Soiling of clothing or bed sheet, passing of cloths of more than 1 inch, and of course, we said that flow is more than 8 days. And most important, as per NICE, the quality of life, something affecting her physical, social, and culture, all that would be the quality of life. So these are the various ways to know that heavy menstrual bleeding is happening. So in the exam they will ask you this. Just click the slide. Did I put any more questions? Yeah, nothing. Yes, go on. Now I'm not able to see the top, what is the heading I have given. Okay, now I think I've
Acute
got
AUB, ma'am.
acute AB because you are viewing Sahita Shield screen. It's showing something like that. So I'm not able to see the heading. Okay, it's okay. It's the management of acute AUB. Yes. See, in the students often start with IV estrogen, isn't it? When we ask them with acute AUB, how do you manage? But in practice, I have not did not have any opportunity, or I don't have. I'm not used. I don't know whether there is a supply availability and all that. One is that. And second is when you use high level of estrogen, the risk of thromboembolism, vomitings, severe vomiting, hypertension, the side effects are so many with the conjugated IV estrogen and giving monophasic pill 3 times a day, 3 tablets a day. Maybe practicality, we don't use these conjugated equine estrogen, but it is really wonderful to know the mechanism of action of estrogen. How does it control the bleeding? It causes re-epithelialization. That's what happens on the re-epithelialization. In a normal menstrual cycle starts from the second day, 48 hours. or max from the third day. So it starts, reepithelialization happens, it stabilizes the lysosomal enzyme which have been destabilized by progesterone, and there's a clotting at the capillary level, there is increase in the coagulation factors, there is an increase in the fibrinogen, there is an increase of a platelet aggregation. So in short, there is a repair happening, there is a stopping of the degeneration and the clotting mechanism. So these are the mechanisms by which estrogen works. And now, what do we normally give and what do we answer in the exam? It is the progestin. In the progestin, it is most of the time norethisterone or norethindrone. And in the exam, we always ask you what is the dosage. The dosage would be high again, 5 milligram 3 times. For how long again? So examiner should not be asking you the preparation, the dosage, the duration in one go. You have to tell that I will start off with 5 milligram 3 times for at least 1 week to 10 days, then taper it to two times for the second week, followed by one the third week, and then she'll have a progesterone withdrawal bleed, and then I will go with the maintenance dose. With then the examiner will ask whether continuous or a cyclical. So you go with generally with a cyclical from the 5th to the 26th. Now some of you keep answering that you will be giving her only in the luteal phase. See, it is an acute AUB. You will have to continue with the from the 5th to 25th or 26th day, not in the luteal phase, because you have managed an acute AUB and you don't want it to happen again and again. So the answer would be cyclical, and from the 5th day to the 26th day of the menstrual cycle for the minimum of at least 6 months. Any treatment, medical management is up to 6 months. And the other drug would be medroxyprogesterone. Again, high doses only 3 times, and again it goes by a tapering dose for the next 3 weeks. So remember, this is the common answer you'll have to be giving in the exam. Start with norethisterone, norethindrone, or medroxyprogesterone. Tell the examiner that you'll be giving higher dose 3 times, and you go with the tapering, and then you talk about the maintenance dose. This is only theoretical. The estrogen is only, though wonderful, it is theoretical. And if you look at how this progestin is going to act, see, the great thing, why we choose only these drugs, because of its hemostatic effect. And 10% of what norethisterone 5 milligram 3 times, when you give 10% of this, is converted to estrogen. So ultimately it is the estrogen which is helping the acute AOB. It is not the wonder done by progestin. The wonder is being done by estrogen because it's of its conversion to estrogen. That is the potent estrogen, ethinyl estradiol. Sometimes we ask you what is the how it is acting as a hemostatic effect. Then you say that 10% of this progestin is converted to a potent ethinyl estradiol, which is causing all this reepithelialization, all this repair, stopping the degeneration, that is the lysosomal enzyme, and the clotting, capillary level, coagulation, fibrinogen. The mechanism is the same. Hope I made it clear. Next, the other drugs which are used for acute AUB, and remember then DMPA, that is your dipomedroxyprogesterone acetate, and GnRH are not to be used in managing acute AUB because they take a longer duration for the onset of action. So these are not the drugs of choice. What are the other drugs of choice? It's the Trenexa and tamponade. We had one or two occasions where we had to put a tamponade in a case of acute AUB, perimenopausal age group. We had to put a tamponade, and the ideal size would be not 12, 13, 14, 16, 18 like that. A bigger size Foley's catheter, and distend it to 30 ml. And if medical management fails or not responding, the other way of managing the surgically is, if you have the facility, you go by uterine artery embolization, especially AV malformations with heavy bleed. We refer to NIMS for uterine artery embolization. If we do not have this facility of ablation, At times we had to go with hysterectomy and also hysteroscopy directed DNC. Combine this with hysteroscopy, that would be ideal. But doing hysteroscopy when there is a heavy menstrual bleed is also difficult. You will not be able to visualize the cavity properly, so we go with the DNC, thorough DNC, and these are the options. So on imaging, if you have subjected a woman of AUB for imaging, that is the scanning, that is transvaginal scan, and you find a normal or thick endometrium, what does it indicate? If you find a thin endometrium, what she is giving a history of heavy menstrual bleed, but imaging says it is thick, or imaging says it's very thin. How does it matter to you? What do you understand this finding of normal or a thick endometrium in the case of heavy menstrual bleed?
Thick endometrium means the endometrium has been exposed to estrogen during the first half of the cycle.
Okay. Thin means it's not exposed to estrogen.
Uh, the amount of estrogen will be less.
Now you are right. So both the endometriums are exposed to estrogen. But as I told you, here normal or thick endometrium following a heavy menstrual bleed indicates she is hyperestrogenic. The estrogen, she is exposed to high estrogen. In such a case, when you do a biopsy, you expect hyperplasia, either with atypia or without atypia. But here you expect a hyperestrogenic. That means you are dealing with a woman with hyperestrogenic status, and there you will have to be very careful in excluding endometrial cancer. Got it? Got it? Did you
Yes,
understand?
ma'am. Yes,
And
ma'am.
this is the candidate who is going to respond to your progestin, unopposed estrogen, hyperestrogen. This is the candidate who is going to respond to your progestin. The second candidate who has thin endometrium has been exposed to estrogen but very low level of estrogen, and here it is represented by a basal layer only. This woman is not going to respond to your progestin. To control bleeding in a case of thin endometrium, you will have to give estrogen and then progestin. Got it? And here the risk of malignancy is less. Did you understand the difference?
Yes, ma'am.
Yeah, Navina. So it is high estrogen. This is a low estrogen. She is high risk for endometrial cancer. Here you expect hyperplasia as a histopathology. Here, thin endometrium, do not attempt a endometrial biopsy. You will not get anything. Here you will have to start her on estrogen plus progestin to manage the condition. Here, progestin alone to manage the condition following a biopsy. Here, histopathology is required. Here, biopsy is not indicated, but estrogen followed by progestin, or estrogen plus progestin is the management for the second case of thin endometrium. The management, the interpretation is totally different. Okay, next slide.
Next slide, ma.
Yeah. As I said, these are the two things: Trenexa, tamponade, surgical management. We finished with this, right? Again, we have come to the same slide. Yeah. Now we are going with the proper FIGO class 2, that is the structural and the non-structural. I've started with the palm coin now. So with the AUBP, we have two types of polyps: functional polyp, non-functional polyp. Non-functional means by if you do a scan and somebody says there is a polyp, but they don't have any disturbance, they don't have any menstrual disturbance, that is the non-functional polyp. Functional is they are symptomatic. How to differentiate? They're smaller, but they are naughty. These are little larger, but they are non-functional. They don't bleed. They are whitish on a hysteroscopy. If you do a hysteroscopy, it is pink, almost similar to that of the endometrium. But when compared to the adjacent endometrium, they are whitish. On a Doppler, you see a single feeding vessel, that the feeding artery sign it is called, which is very specific. But here we see the surface branching. All these are what I'm trying to tell is the hysteroscopic. By chance you have done a hysteroscopy, these are the features of a non-functional polyp. Again, we have got two varieties of polyps, single polyp and multiple polyp. A single polyp, the answer would be, because if they are symptomatic, especially when they are in infertility, unless you get rid of this polyp, they will not conceive. So ideal is always not a blind biopsy, it is hysteroscopic polypectomy. And also the adjacent endometrium, never forget to have any abnormal looking endometrium or adjacent endometrium has to be biopsied along with the polyp, because they have seen that pathology happens in the endometrium where is adjacent to the polyp. So if you don't find any abnormal area on hysteroscopy, you select the area which is adjacent to the polyp and take a biopsy, and you can go ahead with LNG to prevent polyp coming up again and again. You can give this option to the woman beforehand and you can go ahead with this LNG. But when it comes to multiple polyps, hysteroscopic polypectomy, and you send every polyp for a biopsy and also pick up abnormal looking area or all that adjacent to the polyp you biopsy, and you send it for histopathology. You wait for the report and there you rule out malignancy and then only go with the LNG. So single polyp, in the same go you can go with the LNG. But for multiple polyps, you wait for the histopathology report and then only go with LNG to prevent a recurrence. Why? Because in multiple polyp, there was an observation that some of them can be pre-malignant and or malignant. If malignant, the management differs. So this is the lesson from the single polyp and the multiple polyp, and functional and non-functional. Next. Now, there are sometimes we ask in the exam, what are the varieties of polyps? You know, so endometrial polyp, it's a histological diagnosis when you find both gland and stroma. It is an endometrial polyp. Along with the gland and stroma, if you find smooth muscle tissue, it is adenomyomatous polyp. So these are the varieties of polyps. Next. Yeah, why a polyp should bleed? So these are the reasons, causes for the bleeding when the woman has a symptomatic polyp: because of the fragility of the vessels, because of the chronic inflammation which happens on the surface of the polyp, erosions on the surface of the polyp, the necrosis, ischemic necrosis of the apex. So the polyp is exposed to inflammation, necrosis, erosions, and vascular fragility. This is the reason why they have the bleeding, mostly intermenstrual bleeding. Sometimes in the exam we ask during the instrument session, pick up the instruments. If you are dealing with the hysteroscopy, pick up the instruments with which we will do the polypectomy. So you need to know these identify and pick up these instruments to do a polypectomy. But now the latest, especially when you're dealing with the case of infertility, I said the conception rates are higher if you do a polypectomy. We are not using any energy sources because they can cause damage to the endometrium. So what we are doing is doing the polypectomy with scissors rather than with the energy sources. If at all energy source has to be used, bipolar is preferred over monopolar because of the less radiation to the adjacent endometrium and less damage to the endometrium. Next. Yeah, full thing you do. Yeah. So another question we ask in the exam is, what is the differential diagnosis for a polyp? So one is the submucous fibroid. How do you differentiate a submucous fibroid from a polyp? It is the Doppler is the answer, because you find a rim-like vessel pattern in the Doppler, whereas in a polyp, as I said, there is a single feeding vessel like this. Single feeding vessel, the pedicle artery sign is there for a polyp, but for a submucous fibroid, it is a periphery, whole of the periphery, that is the rim-like vessel pattern is seen. Another differential diagnosis would be a diffuse thickened endometrial endometrium, which is seen in hyperplasia or endometrial cancer. How do we differentiate? Doppler is very important again. It is the multiple feeding vessels if it is an endometrial cancer. So the answer is Doppler is a must to differentiate polyp from a submucous fibroid or a diffusely thickened endometrium or an endometrial cancer. So whenever you are writing in the exam or answering along with the transvaginal scan, do not forget to mention about the Doppler. And what is the ideal time to do a order for a scan when you're suspecting a polyp like an intermenstrual bleed she complains of? So ideal timing is post menstrual. Why do you think it has to be post menstrual? Why not a pre-menstrual? Navina, Sarata Devi, see few names over here. So why do
And
you think yeah,
post-menstrually, the endometrium will be thin, so we can visualize the polyp more clearly.
okay. Okay, so post menstrual, especially on the third day, if you can do immediately where the bleeding like tapers little, third or fourth day, the advantage is if you ask for a scan on the third or a fourth day, some amount of menstrual blood is still there in the cavity. It almost is like a cis saline infusion sonography. So, some amount of the menstrual blood on the fourth or the fifth day acts like your saline infusion sonography, and your polyp becomes more prominent. As she rightly said, as Navina rightly said, the endometrium is thin. But what I'm trying to add is the small amount of the menstrual blood acts like a cyst, and it and the outline is very clear. If you do it premenstrual, as she rightly said, the secretory endometrium is thick and it is difficult to differentiate because we know the advantages of cysts, but very few centers are doing saline infusion sonography. So I utilize the fourth or the fifth day of the menstruation to see this good the polyp, because this, look at the features. Because here it says acute angle to the endometrium, intact endometrial myometrial interface. These are the ultrasound features. These are highlighted very well when some amount of small amount of menstrual fluid is still there in the menstrual in the uterine cavity. So did you understand the advantage of doing it premenstrually, post-menstrually,
Yes.
especially on the fourth or fifth
Yes,
day
yes,
would
ma'am.
be ideal. Yeah, yeah. Thank you. Next slide. Yeah, sensitivity of cis, though we say it is high, I don't know, most of the centers still are not doing it, but probably for some, when we strongly believe that it is because of the polyp, we should be, especially post-menstrual, post-menopausal bleeding. Polyp is one of the causes. And probably in such cases, we have to insist on saline infusion sonography because the the predictive value is very high, 100%. Yeah, next slide. Yeah, please. Yeah, here I would like to discuss about two cases. See, she is a perimenopausal woman, symptomatic, and the diagnosis is made as a polyp with single feeder vessel. So, diagnosis is done. Another lady is postmenopausal. She's totally asymptomatic, and here also a diagnosis is done as a polyp. Both the ladies have polyps. The perimenopausal woman is symptomatic, the postmenopausal woman is asymptomatic, but the pathology she has is a polyp. So, how do we manage these two situations? The pathology is P. She doesn't have AUB. This lady has an AUB, but the age groups are perimenopausal and this is postmenopausal. A quick response, please.
For postmenopausal hysteroscopic evaluation, and if we see the polyp, polypectomy.
Okay. I told you just now, whenever you remove a polyp, take a biopsy from adjacent area.
Yes, ma'am.
Don't forget that. Or if you see any abnormal area, you take a biopsy from there, but always take a biopsy from the adjacent area. Okay, don't forget that. Okay, that could be your answer for this lady who is symptomatic. Perimenopausal symptomatic?
Perimenopausal also hysteroscopic polypectomy can be done, ma'am.
Yeah, can be done, and you can put off LNG IUS also, isn't it?
Yes, ma'am.
Yeah. See, you don't want a recurrence. She doesn't want a recurrence, and you also don't want a recurrence. So, better to put a LNG. That is your answer now. So, now let us look at the recommendation. Next slide, please. Yeah. See, what the recommendation says is look at the risk factors. Please always remember, you always have to look at her risk factors for endometrial cancer, just not the polyp, functional, not functional, one, multiple. Look at the risk factors for endometrial cancer in the woman as a whole, the family history, obesity, BMI, all that which we have discussed till now, diabetes, hypertension, corpus cancer syndrome, all that you keep in mind whenever you are managing a case of AUB. That's the point number one. So, at patients highest risk of pre-malignant or malignant are older in age, they are symptomatic with postmenopausal bleeding and tamoxifen. The recommendation is if the woman is on tamoxifen or if the woman is symptomatic and she is postmenopausal. Our lady was postmenopausal, she is not on tamoxifen, she is not symptomatic. So the answer is we need not do a hysteroscopic polypectomy and DNC, isn't it? Our lady was postmenopausal, not symptomatic, and not on tamoxifen, isn't it? Am I right
Yes,
or wrong?
ma'am.
Yeah.
Yes,
But
ma'am.
what I'm trying to tell is, but look at her other risk factors because I have not told you about the other risk factors. I didn't give you her BMI. I didn't give you her diabetes status. I didn't give you the family history. So look at those risk factors. If the risk factors for endometrial cancer are there, do not hesitate to go for this hysteroscopic removal, even if she is asymptomatic, and go ahead with the biopsy. So the underlying point is look for the risk factors. Now, patients at intermediate risk and they are postmenopausal with no symptoms or premenopausal with abnormal uterine bleeding, expectant management can be considered for asymptomatic patients with low risk factors for malignancy and follow up. So, for the first woman who was premenopausal, hysteroscopic polypectomy plus endometrial biopsy of an abnormal area or adjacent area, and you can go ahead with the LNG is the answer. For the other lady who was postmenopausal and she was asymptomatic, not on tamoxifen, the answer is look for the risk factors of endometrial cancer. Again, I'm repeating her BMI, diabetes, and then lipid profile, metabolic syndrome, family history, and then take a decision. Just because she's asymptomatic, you should not leave her alone. Am I clear?
Yes, ma'am.
Yes, thank you. Next. Moving on to ABA. In the theory, you need to understand what is the cause. But the woman also asks, nobody in my family has adenomyosis. Why did I get it? So there is an embryological theory, nothing can be done for that. It's the stem cells and the trauma. So in the history, if they're giving you a history of a DNC or a C-section or a myomectomy, that trauma could be responsible for the AUBA. And why do they have a heavy menstrual bleeding in the AUBA? Increase in the endometrial surface area, increased vascularity, abnormal uterine contraction, something similar to leiomyoma, prostaglandins, and the hyperestrogenic status. Earlier, the diagnosis of AUBA was only histological, but now what do we have? What do we have apart from the history, clinical?
Ultrasound.
Exactly, the Musa criteria. In the exam, somehow we try to ask you what is the Musa criteria. So how many findings are there in Musa ultrasound assessment? Yes, Musa. How many features?
8.
Yeah,
Eight.
yeah, very right. So we'll see what is Musa. Very correct. 8 features. Next slide, please. So try to put up this figure and then practice this figure. Whenever you have a free time, you practice these figures. Asymmetrical thickening, the myometrial cysts, the hyperechoic islands, the fan-shaped shadowing, echogenic subendometrial lines and buds, translesional vascularity, irregular junctional zone, and interrupted junctional zone. So these are the features. Try to learn by putting these figures and you will remember it. So 8 features. Any other way? Okay. Okay. We'll move on to the next slide. Yeah. Any other way means MRI. Always we ask for an MRI to differentiate it from response. I'm waiting for the response. So when do you ask for an MRI?
Adenomyoma.
Focal adenomyosis versus leiomyoma. Fibroid versus focal adenomyoma. Those days when we were not having an MRI, we thought it was fibroid and we posted that lady for a myomectomy. So what finding told us in the during surgery that it was not fibroid, it was adenomyoma? When we were not having an MRI, we mistook it as a case of leiomyoma. Intraoperatively, we suspected it is a focal adenomyoma, not a fibroid, so we could not proceed with a myomectomy. What
In
finding
fact,
has told us?
fibroid will have a capsule. We can easily enucleate.
Yes.
For adenomyoma, the plane of separation will be very difficult.
Yes, very right. So it is stony hard. There was no capsule. We are not able to enucleate. We are unable to enucleate, gritty, hard, and no capsule. So intraoperatively, we have made a diagnosis that it is a focal adenomyoma and it was not a leiomyoma. But we have taken a consent for myomectomy, and now we could not do. But now better instruments are there where we will have to chop off a portion of the myometrium and do a focal resection. Focal resection is possible, and better instruments, electrocoagulation instruments are there, electrocautery, where along with the myometrium you will have to chop off. We cannot enucleate adenomyoma. Okay, that was the learning we had in those days. So these are the MRI features. So practice this. See, as per MRI, it you can get much more detailed information, not only differentiating from leiomyoma, fibroid, but variety of different variety of features, whether it is close to the deep endometriosis, anterior, posterior, subserosal. See, if it is a subserosal and the management becomes different, because LNG does not work so well for a subserosal. Okay, when it is diffuse, it helps. When it is superficial, it helps. So the management also differs. Okay, so this is another picture you need to see. Submucosal also it is there. So you can get confused with a submucosal fibroid. So MRI is a must whenever you are going with a conservative management, apart from your ultrasound. Okay. Next. Yeah. Now another scenario where we went wrong actually. It's a 46 years Paris lady, 2 previous section, heavy menstrual bleed and secondary dysmenorrhea. The diagnosis was much easier. The ultrasound has given a diffuse type of adenomyosis with ET 12 mm. We went ahead with DNC and with the LNG insertion. The biopsy report came as secretory endometrium with focal hyperplasia without atypia. This is focal hyperplasia without atypia. So, how to follow her and whether to do follow with the transvaginal scan ET or with the endometrial biopsy. So, which one? What is the answer, ma? How to follow her up? Already the treatment has
See,
been given. This is the report.
with transvaginal ultrasound, ma'am.
ET with transvaginal ultrasound rather than biopsy. But the recommendation is we will have to repeat biopsy every 6 months, keeping LNG IUS in situ. And this has to be done for at least 2 years and long term follow up, that is annual basis. Understood? For every 6 months, whenever there is a hyperplasia, remember there is a chance of endometrial cancer, though the percentage is less, 1 to 3%. But the recommendation is do a biopsy with LNG. Do not remove the LNG. Just do the biopsy every 6 months. That means one time, two times, three times, four times. In 2 years, she'll have four times EB. The people curate, you do the EB and see whether it is reversed. This focal hyperplasia has reversed. And as you said, why ET is not advocated or recommended and why biopsy? The answer is here. Absence of validated reference ranges for ET in a perimenopausal reproductive age woman. In a postmenopausal woman, we know that ET of this much thickness can rule out endometrial cancer. ET of this much thickness, more than this thickness, can cause endometrial cancer. But for perimenopausal women in the reproductive age group, there is no validation of any cutoff value to say below this you are safe, above that you are unsafe. Okay, and measurement of ET with LNG IUS in place is difficult by most of the sonologists. So you can be mistaken. You may be given a 4 mm or 5 mm and you are happy, but still the pathology may be going. So you will have to look at the pathology, histology, not at ET during the follow up of a focal hyperplasia without atypia. Is that clear?
Yes, ma'am.
Yeah. So it is not ET monitoring, it is biopsy monitoring, histology monitoring. Frequency is six, yeah, 6 monthly, for at least 2 years. And this has to be followed annually because we know that LNG will be there for 5 years. Now they say it can extend even up to 7 years. It works even up to 7 years, and some studies are saying even up to 10 years. Next, AUBA. Yeah, we had another lady. Can you just put only this one, the top portion, and remove? Yeah. So this is another lady. Again, the diagnosis. Now we are getting very good diagnosis on ultrasound. The diagnosis is adenomyosis. We have done a DNC. We have put an LNG, and it has come as focal atypia, hyperplasia. In the previous case, it was secretory endometrium with hyperplasia without atypia. Here it is focal atypia, ma'am. That's the difference. Okay. Now, how to manage this focal atypia? There we have learned we have to do the endometrial biopsy every 6 months for 2 years and then follow her annually to see that hyperplasia is reversed. Isn't it? Here, what could be the management? What is the workup? Any quick response?
And since she is having hyperplasia, this woman also needs follow-up with biopsy, ma'am.
Every
Sorry?
Since this patient is having hyperplasia,
Yeah.
she also needs follow-up with biopsy.
every 3 months, someone has written.
Okay. Okay. Now, quickly we'll go to the answer because we have revealed the answer. That's fine. It's okay. See, if this focal atypia has come, the recommendation is whenever there is a focal atypia, they say you will have to go with a hysteroscopic guided biopsy. If somebody has done a pipple and then they got this kind of hyperplasia with focal atypia, the recommendation would be next time you'll have to go with a hysteroscopic biopsy because entire endometrium has to be studied. because we could have missed if it is a people sample, and rule out coexisting ovarian. What is the cause of this hyperplasia? So study the ovaries. In the follow up, you have to look at the ovaries, and if you see something suspicious in the ovary, solid mass, so solid mass in the ovary, then you will have to even go into the extent of asking for inhibin and estradiol levels, because you'll have to rule out the germ cell tumors if you see a solid mass in the ovary. So for any atypia, the answer is hysterectomy unless is infertility or refuses. So just because you have put an LNG, you need not tell her to continue. You will have to counsel her that a thorough evaluation has to be done. That is hysteroscopically you will have to, if it is a people sample, and then you will have to go with a definitive hysterectomy, because there is an atypia, unless she is for case of infertility or refuses hysterectomy. Say suppose she says, no, anyhow I have this in place, I would like to go, not to go with a hysterectomy, I would like to continue with the LNG, then instead of 6 months, here the interval is every 3 months. But ultimately, finally, she will have to go for a hysterectomy. The ATP always says the risk of malignancy is 25%, and they'll have to go for a definitive surgery, that is hysterectomy. Next recommendation, please. See, every 3 months until 2 consecutive negative biopsies. The long term follow up is every 6 to 12 months until hysterectomy. I don't think anybody will agree for this every 3 months, every 6 months. This follow up is a very, very frequent and a close follow up. So, the other option would be, unless she complies with this type of follow up, otherwise the best is you document their advised hysterectomy in view of focal atypia. Otherwise the follow up has to be like this till she undergoes hysterectomy. So you'll have to be very strict in giving in documenting the and counseling the woman when you see a report of focal atypia. We have one teacher, 43-year-old teacher, who had this kind of similar type of report, and she said she promised to come after 3 months for a biopsy. It has been 9 months now. She has not turned up, and she's lost for follow up. So your documentation only helps you that you have given her a right advice. Next. So we all know this classification. So when here one point I would like to say, most of the 0, 1, 2, 3 are symptomatic, but when you have 4, 5, 6, 7 and she is presenting to you with an abnormal uterine bleeding, please look for other causes of AUB rather than the leiomyoma itself being one of the cause. So 4, 5, 6, 7, look for other causes is the point which I wanted to tell you. Next. 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 Keep clicking. Yeah. So this is another classifications. Whenever you are planning for a hysteroscopic removal of 0, 1, 2 type of leiomyomas, this is a step W classification. Will tell you whether when the score is between 0 to 4, it says you can finish the procedure in one step by hysteroscopic myomectomy. The score is little higher, then you'll have to consider GNRH, and it is a two-step procedure, and much higher of 7 to 9, you'll have to think of alternative to hysteroscopic technique. So this is the step W classification guiding the whether you can deal with it hysteroscopically or not, in one go or two steps, to consider GNRH or not to consider GNRH. So GNRH, maximum of 2 doses are given to reduce the size when the score is between 5 to 6. Step W classification.
0, 1, 2 இருக்கும். Step.
Yeah. Next, please. Yeah, this is a question here. Fibroid at dash position is at greatest risk of perforation during hysteroscopic resection of myoma. Which position, at which position if the fibroid is located, there is a chances that you can perforate.
Cornua.
Cornua. Even I thought it is cornua, but the textbook gives as the central and fundal. I thought it is like you as cornua because that is the thinnest portion, but standard book has given an answer as central or fundal. Central fundal. Yeah. Next. Yeah, this is something interesting. I have used this medicine before it was banned in our country. Selective progesterone receptor modulator. This is a medical management, ulipristal, Pearl 1, 2, 3, 4. Sometimes the examiner will ask you what are these studies about. So you need to read up a little on these Pearl studies. But now DCG has not, there's no approval and it's not no more available, and we are not prescribing ulipristal. It mainly acts by decreasing because progesterone is responsible for maintenance and the growth of a fibroid. The vascularity and the growth factors are produced by progestin. So selective progesterone receptor modulator acts by reducing the vascularity and also by causing apoptosis. It's a wonderful drug. And why do you think DCGI has stopped the approval of this ulipristal? It's a wonderful drug, but why? Reduction in bleeding, size, everything.
Liver cancer.
Cancer. So it has the DCGI has stopped approval because of one deadly complication, liver failure and need for liver transplant. Liver failure, totally liver fails, and there was a need for liver transplant. So that was the, I see some answers. Thank you for that. Liver toxic. So hepatotoxic and liver transplantation, to the extent of liver transplantation. That was the huge damage it was doing to the liver. So they, for some days, they said, do an LFT baseline and then stop the medication after 3 months, again repeat the LFT. So for few months, I was using that way with the LFT monitoring, like
But it
anti-tuberculosis.
has come back, not come back, Amalti. Again, it is.
No, no, it
Oh,
has not come back.
give.
DCGI is not approved after the
Okay.
Europe incidents.
Okay.
Now, no medical rep also is coming and talking on this now.
Okay.
So, what do you think the latest drugs could be for leiomyoma medical management? Anybody? We did a study in MGMH Petla Burj on this.
Prestone.
Sorry?
Mifepristone.
Mifepristone. That was an old study. Mifepristone 25 mg. See, with mifepristone, again, there are not of much studies. The latest and FDA approved and drugs now are GnRH antagonists. Why? Because mifepristone, what it does is, it is antiprogestin, right? Because of antiprogesterone, it is an antiprogesterone. So what is happening? There is an unopposed estrogen effect. So long term studies are not there with mifepristone, and because of the unopposed estrogen, again there can be problem to the endometrium. So that's why there are no long term studies for with the mifepristone. We have used mifepristone 25 mg and 10 mg and 25 mg, but it is not FDA approved, and I'm little scared to use those drugs. When I read that antiprogesterone, and there is, because of antiprogesterone, the estrogen is one. There is a continuous exposure to the estrogen. There's no protection of progesterone. So the endometrium effect on by the estrogen, we really don't know. So that is the problem with the mifepristone. Yes, it was used as you rightly said, but not now. So the latest drugs are GnRH antagonists. We are started using now antagonists. We did a study also in our institution. Next, please click on elagolics and relagolics. Please click on, click. Yeah, elagolics. So the this is approved, both are approved. There is a study on relagolics that is called the Liberty study. Both are approved. Here the advantage of relagolics over elagolics is, this is a single dose, single oral, and single, both are oral, single oral dose. Here it is like a BD dose, it has to be given twice daily. So that is the difference between the two. Next. See, the superiority of antagonist over agonist is, there is a there is a flare effect. There is a flare effect when you give agonists, isn't it? And there is a hypoestrogenism, and menopausal like symptoms come with agonists. So there is no flare effect, there is no hypoestrogenism, there is no those ill effect of hypoestrogenism on the bones and all that with the latest antagonists. Because if you look back, previous slide please. If you look back, they're just not antagonists, there is a combination. Previous slide, because they may ask these two drugs in the exam. Previous slide.
The previous slide, Saiti.
Yeah. See, if you see, it has a combination of estradiol 1 milligram and norethistérone 0.5 mg. So this is the additional advantage. Antagonist, no flare effect, number one. Second, it is a combination of these two, estrogen and norethistérone. So there is no hypoestrogenic side effects. So that is why it does not need any add back therapy like agonists. Okay, that's the advantage of these two oral drugs. Next. So in the exam, we commonly ask, what is the cause of heavy menstrual bleeding in leiomyomas? So increase in the surface area. Normal is 15 square centimeter. From there, it can increase to so much 200. Local hyperestrogenism, endometrial hyperplasia, the endometrial polyps, chronic inflammation, ulceration, interference with the myometrial contraction, thereby the vasoconstriction, the venous congestion in the myometrium. These are all the reasons. Whatever you remember, you tell. These are the reasons for the heavy menstrual bleed in AUBL. And the risk of malignancy in leiomyoma is just 0.1%. But there are so many litigations where they thought it is just leiomyoma and gave us conservative medical management, and finally after few years of follow-up they turned out to be leiomyoma, and there are cases where they were implicated. So it is a really difficult situation, though the incidence is less. So always write, document, needs a follow-up. Whenever you give a conservative management, she has to come for a follow-up. Why? Because if a rapid growth is there clinically, or an ultrasound, or any abnormal vascularity, or she becomes symptomatic, you'll have to operate. So document and then ask her to follow up. That is the only way to protect ourselves in this medico legal era. Next. Next. Yeah. Mention two reasons for asymptomatic fibroid becoming symptomatic in a postmenopausal age group. See, we always say, no, womb in the tomb, once the menopause atrophy happens, it will be asymptomatic. But I have seen some cases where it has become symptomatic for the first time after she reached menopause. Yes, very good. One is sarcoma, endometrial cancer, sarcoma. Okay, any other? Another textbook, standard textbook, has given an explanation. See, in a menopausal woman, there will be myometrial atrophy. So, if myoma, which was like type 3 or type 4, which was lying in the myometrium, once there is an atrophy, it gets pushed towards the endometrium. That's how it becomes symptomatic. It need not be sarcoma all the time. Sarcoma, we just read that it is only 0.1%. So, menopause, myometrial atrophy, the 3 or 4 type of leiomyoma gets shifted because of the myometrial atrophy and gets shifted into the cavity, and now it starts becoming symptomatic. We have seen such cases. So answer is that, and of course leiomyoma, sarcoma also. Next. Yeah. Here, she is a 36-year lady. She had one miscarriage 4 years ago. Now she complains of heavy menstrual bleeding. All symptoms of anemia is there. Per abdomen, it was mimicking like a fibroid, 16 corresponding to 16 weeks. Ultrasound says uniformly enlarged, and the ultrasound says it was a submucosal fibroid, 14 centimeter. enlarged cystic ovaries, but and the endometrial biopsy, when it was attempted, there was a lot of bleeding and clots. There was no hardly any endometrial tissue obtained. Because of the heavy bleeding, they abandoned doing the biopsy. They posted her for TH with BSO, but they found the tissues were very friable and there was a massive bleed. You know what the histopathology came as? Choriocarcinoma. So it has come as choriocarcinoma. Another case, there was a bulky cervix, normal size uterus, and it was reported on ultrasound. So most of the cases, I think, we are just going by ultrasound. If ultrasound says submucosal fibroid, we are thinking it is only submucous. If it ultrasound says it's a cervical fibroid, normal size uterus, biopsy was not done here, and it was an endocervical cancer. So what do you think, how did we miss? Why did we miss? So here the learning point would be, give importance to this miscarriage 4 years ago. See, choriocarcinoma unfortunately can follow a term pregnancy, following a normal abortion, it can follow a molar pregnancy. That is the deadly disease. So I feel very strongly that we will have to include serum beta HCG or urine pregnancy test for every woman of AUB. We cannot afford to uh, see enlarged cystic ovaries. Even we find cystic ovaries in even in leiomyoma, isn't it? Because of the hyperestrogenic status and all that. So everything we can correlate. But the lesson here is never miss out pregnancy related causes. Beta HCG I feel is a must, and we started incorporating beta HCG in our workup of AUB. And here, see, there was a heavy painless bleeding, and just because they said it is a cervical fibroid. So I'm telling you, please feel bimanually, feel for the cervix. If it is ballooned out, it is firm in consistency, you just ask for Doppler and see what is there, what is the blood flow of this fibroid. Somewhere we could have got a clue that we are dealing with an endocervical cancer. And this is how cases can look simple, but at the same time they can become so complex, and it is so difficult for us to answer. The entire treatment is different and difficult. Next, please. So some points about choriocarcinoma, please click the slide. Yeah. No, where is choriocarcinoma? Yeah. So that's what, it does not just follow a molar pregnancy, it follows even a normal pregnancy and an abortion. And these are the patterns of bleeding. Profuse bleeding when you encounter during DNC is also one of the indicators that it could be a choriocarcinoma. There was no tissue obtained, only blood, and they were scared and they just abandoned. And those cysts could be a theca little cysts which were seen in the ovary. Color Doppler definitely could have been done in that case. Abnormal vascularity would have at least given us a clue that something is going wrong. It is not a submucous fibroid. So mention two conditions where massive bleed can occur during a DNC. One, we have learned that this is, yes, very good, AV malformation. Any other? Choriocarcinoma, endometrial cancer. So all malignancy, endometrial cancer, then choriocarcinoma and AV malformations, we will have to exclude before we do an DNC. Otherwise, it's going to be very torrential. So don't forget Doppler whenever you are evaluating a case. That's the lesson. Next. Next. Yeah. So risk factors for endometrial cancer, that is type 1. So type 1, see, family history, it is a risk of 60%, high fat diet, prolonged exposure to estrogen, tamoxifen, metabolic syndrome, and all this we know, early menarche and all. So keep this list in mind when you're taking a history. Highlight these points. Whenever you see any of these, please highlight. She is a high risk candidate for endometrial cancer. So this is what I wanted to convey. Next. In PCO, in one of the textbook it is given, An endometrial thickness of less than dash probably has low risk or a less risk of endometrial hyperplasia. How much of thickness in a PCO probably says that endometrial hyperplasia is not going to be there. We just discussed, no, ET, importance of thin ET, thick ET, but in a PCO, okay, it is 7 mm. It is given as whenever it is less than 7 mm, probably the risk of endometrial hyperplasia in a PCO woman is less. If you see more than 7, it's again to be highlighted. So protective factors, this is something we ask in the exam. Yeah. So 1 year of COC. I think we somehow women are, there are so many questions when we ask them to use oral pills. So many complications they're scared of. But look at the advantage. The protection for 1 year of use is as long as 15 years, 40% reduction in endometrial cancer. Diet rich in fruits, vegetables, and fiber, physical activity, and progestin use along with hormone therapy. These are the protectors. The one which we can recommend and advocate and advise and tell the woman awareness would be, I think, on COCs. Yes. Next. Yeah. Can anyone answer this? What should be the ideal duration of progestin to prevent endometrial hyperplasia if the woman is on hormonal therapy? If you're giving MPA or norethindrone 5 mg, for how many days would be an ideal duration to prevent hyperplasia? 7 days, 10 days, 12 days. Because see, progestin use with hormone therapy is a protective factor. So for how many days you will have to prescribe progesterone? One answer I
12
got
days.
10 days. I got one answer 10 days. Said
12
any
days.
exactly. So it is 12 days. So remember, this is important because on hormone therapy, they are at risk. So give it for, these are the 2 drugs which are recommended. These are the doses and this is the duration, 12 days. Not 7, not 10. Yeah. Next. So this is something recommended by ACOG, which says if there are no risk factors, then consider after 45 years. ACOG and FOXY, they say 40 years. And if there are risk factors, even less than 45 years, you'll have to consider. So bottom line is always look for the risk factors for endometrial cancer. Now, age, of course, is important, but looking at the risk factors and highlighting in the history is important. Yeah, next. On imaging, dash thickness, endometrial thickness has a negative predictive value for endometrial cancer, especially in postmenopausal women with bleeding. This is well-known figure. I think all of you can answer. Simple question. If the thickness is this much,
4 mm.
exactly. So 4, somebody said 5, okay, but mostly it is taken as 4 mm. 4 mm and less, you can, the predictive value is 99%. Yeah, next. So indications for endometrial biopsy, the absence of AUB. This is something interesting I thought I should tell you. Whenever you do a cervical screening test and there is an AGUS, atypical glandular cells in a woman of 30 years, 35 years or older, go with EB. Okay, endocervical curettage and endometrial biopsy. And,
Yes.
yeah, whenever there is a Lynch syndrome, whenever there is a Lynch syndrome, okay, family history is positive, there is a recommendation that every 1 to 2 years starting from 35 years they'll have to go for endometrial biopsy. This because the lifetime risk of endometrial cancer is said to be 61. So history taking, please highlight these points. Somebody is on medical management, that's what we have seen till now, and on LNG with endometrial hyperplasia, we have learned that every 6 months they'll have to go for a EB for the first 2 years, then annually. That's what we have learned. Now what are the Indications, huh? Okay. No, we finished this. Indications. Contraindications also we'll have to know about for biopsy. One is absolute, always rule out pregnancy. Relative would be this: infections, large obstructing lesion from the cervix or upper vagina, coagulopathy, cervical stenosis. These are relative contraindications for endometrial sample. More than contraindications, there'll be a difficulty in cervical stenosis. Yeah, next. So when to suspect the uterine cavity is not entered? See, you pass the uterine sound, but something tells you that you have not entered the cavity. What is that length? Which tells you that you have entered or not entered. What is that figure? Uterine cavity entered or not entered. What is the length? What is the figure I'm asking? Centimeter.
It should be more than 2.5 centimeter.
Okay, you think 2.5. So if your uterine sound has not gone to a depth of at least 6 centimeter, 2.5 means you are in the endocervical canal, ma'am. That means you have reached the internal os. 1 inch, cervix is 1 inch. So 2.5 centimeter is you are in the cervical canal only. The answer, question is, when do you suspect you have not entered the cavity? Because endometrial biopsy you'll have to take out from the cavity. So any time you pass the uterine sound and it is less than 6 centimeter, postmenopausal uterus is also almost 6 centimeter. Less than 6 centimeter, you always think that you have not entered the cavity. That's a clue. Next. Next. How do you correct the uterocervical angle while passing the uterine sound? You will have to negotiate this angle when you're passing. How do you do it?
Pull the while holding the lips of the cervix with pulsatile. When we give the traction outwards, the angle will be corrected.
Exactly. Not the lips of the cervix, is only anterior lip of the cervix. So you
Anterior.
stabilize, yeah, you stabilize the anterior lip of the cervix either with the tenaculum or the valsellum, and as you rightly said, outward traction will correct the angle. Not the cervical lips, it's the anterior lip only. Yeah. Next. Yeah. So we have the PIPL, we have the Novax curate, we have DNC, we have hysteroscated biopsies. But another important thing I would like to tell you is what is the adequacy of sample? Sample adequate, sample inadequate, cannot give any information. That's what the pathologist write. So adequacy of sample has been defined only when the pathologist is able to see the gland and the stroma. Unless they see the gland and the stroma of the endometrium, they will not say that sufficient sample. Whatever, it's not the size, it is the histology. They should be able to comment on the gland and stroma. So it is generally said it should be at least more than 5 mm, that is half a cent. Yeah, 10 mm is 1 centimeter, half a centimeter. That's the minimum thing we can send. In one of the studies I found that they have given a criteria, minimum criteria, which is different for a premenopausal and a postmenopausal age group. In a premenopausal, they said at least one intact endometrial tissue fragment where the pathologist is able to see the gland, comment on the gland and stroma. In a postmenopausal, they said it should be a 10 endometrial strips to rule out malignancy with a negative predictive value of 100%. That's what this study says. Okay. So the pathologist, if they can see both gland and stroma, then only it is a sufficient sample. For you to say, you will have to see the size at least 1 centimeter or half a centimeter should be there. Okay. Next. Yeah. What is the percentage of formalin you'll have to send the sample for histopathology? If it is more or less, then the tissue is not preserved properly. That's why this percentage is important. You'll have to check with your pathology lab. Exactly. Thank you for that good answer. It's 10%. It has to be always 10%. Yeah. Next. Yeah, and I wanted to the postgraduates to fill up this form or to make a format of this. Relevant history is very important. Relevant ultrasound findings also you should mention. ET 14 mm. If any pap has been taken and the result is out, or any previous abnormal report, you make a mention of that. It helps the pathologist. If in a previous endometrial biopsy, as we said, we did a biopsy, it was focal atypia, and now you are going with, you have placed the LNG, and again you have repeated the sample after 3 months. So previous report also you please mention in the requisition. If she is on hormones, also you please mention that you have started her on progesterone. Method of sampling, whether it was a pipple or DNC or a hysteroscopic guided biopsy, also please mention, apart from all this quantity, color, and friability, age, and all these details. So these are something very important. A pathologist always, it helps us, helps the pathologist means it will help you and the woman. Next. And the people, we know how to do it in 3 steps, but the detection rate is very high in a postmenopausal woman. So here the people can miss if it is a polyp. If it is a polyp, go with hysteroscopic guided, don't go with a pipple. If it is submucous fibroid, also it can miss. Focal lesions, endometrial cancer, people can miss. That's why if you have done a focal pipple biopsy and it says focal atypia, the recommendation is go back and do a full hysteroscopic guided biopsy, because here it said focal. It could be multiple, it could be multiple areas, maybe multiple areas which people has not picked up. That's why these are the things which can be missed with a people, but this is an office procedure. Yes, next. So DNC, the 4 walls, all the 4 walls, including the fundal region, has to be curated. In spite of a thorough curettage, only 50 to 60% of the endometrium is curated. That means 50% of the pathology you will know, 50% still there is a chance that is you can miss. That's why hysteroscopy is superior over a blind DNC. Okay, so difficult dilatation or failure. So anticipate in these conditions. All these conditions we have faced in our practice till now, where we have posted the woman pre-misoprostol era. I'm talking of pre-misoprostol era. We had all difficulties with all these group of conditions which I have mentioned here. So it's a good practice now to prepare with PG even 12 hours prior. And in difficult, these are the difficult situations. If you have, plan it ultrasound guided, and also mention in the consent that there could be a difficulty in entry and you may not be in a position to do an endometrial biopsy, because in a private practice they pay for the biopsy beforehand, some advance they pay. You take them to the theater, they take admission, daycare admission, they assume that we will be successfully taking a biopsy and sending it for histopathology, but finally you are not able to enter the cavity. It just goes for 2.5 centimeter and not going into the cavity, less than 6 centimeter. That means you are not able to negotiate, so it would be a failure. So make a highlight these conditions in your history, in your case record, and say we are trying. Sometimes there could be a difficulty, we may not be in a position to successfully take a sample. That is important in this era of medico legal. And dangerous perforations is caused by which instrument can cause a dangerous perforation?
Uterine sound.
Sound is doesn't cause dangerous. It is the curette and the suction cannula. So curette and suction cannula is much more dangerous than a curette. These are the two instruments which can be cause dangerous perforation. Next. Dangerous site. Which could be a dangerous site? It's the lateral, because uterines are closer to that. We have seen this all these complications. Lateral are dangerous. And two dangers of perforation, it's not fundus is excusing, nothing happens there. Lateral is closer to the uterine artery. Two dangers would be hemorrhage and bowel injury, both are dangerous. Okay, so what are the indications of hysteroscopy directed biopsies? I put up so many examples here, so I'm not going to read up. So these are the indications for hysteroscopic directed biopsy and reporting. As a postgraduate, we should know how to report, how to send a report. So here, endocervical canal. Start from the endocervical canal. In the notes, you will have to write like this: canal, internal os, isthmus, cavity, and then go into the endometrium. And you'll have to describe like this. Okay. Yeah. Next. Next, yeah. So results of how to interpret the results. This is what we ask in the exam. So you get a proliferative endometrium, it indicates follicular phase. Proliferative endometrium in a postmenopausal woman indicates what? Excess estrogen. It should be atrophic, but if you find this in a postmenopausal, it is estrogen. In a reproductive age group or perimenopausal woman, it indicates follicular phase. Secretory indicates luteal phase. If on progesterone, it could be because of the drug effect. Disordered or crowded glands indicates anovulatory cycles due to prolonged unopposed estrogen. This is something we ask in the exam. If the woman is on COC, you get this kind of report: endometrial gland atrophy with residual changes. And then plasma cells in the endometrium. What is its significance? Presence of plasma cells indicates chronic endometritis. Presence of lymphocyte is something which we see in normally on the second and the third day we see lot of lymphocytes getting migrated into the endometrium. So this is normal and plasma cell is pathological. Next. So WHO initial classification was like this: 1, 2, 3, 4. But now it has simplified as hyperplasia with atypia, hyperplasia without atypia. Now it is simplified into only from 4, it is boiled down only to 2. Next. Yeah, this is the latest: hyperplasia without atypia and hyperplasia with 9 o'clock. Hyperplasia without atypia, hyperplasia with atypia. This is the latest classification. Next. So how to manage endometrial hyperplasia without atypia? We have just discussed, isn't it? Without atypia, it is always progestin. These are the various combination, but remember, it always has to be a continuous therapy, not cyclical. And I said atypia, always hysterectomy. Always hysterectomy. Only in cases of infertility or the woman is not willing for this hysterectomy, then only LNG comes as a second option. But whenever you are giving LNG as an option, please rule out granulous or cell tumor in the ovary. Do a thorough checkup. Don't just go and give a medical management for a case of atypia. I'll just show you what is the second option. Can you click? Yeah, see the second option, it says whenever there is an atypia, now immunohistochemistry has become important. Whenever there's an atypia on the histopathology, ask for immunohistochemistry. Medical management is not the choice. Immunohistochemistry, MRI, CT chest, everything has to be done very thoroughly to say whether how far the disease has spread and what is the prognosis, what is the whether she's going to respond to progestin or not. All this has to be done, and then only you give her the second option. Don't give her this second option. Always better to give only hysterectomy as an option when there is an atypia. Next. Which conservative procedure is contraindicated for endometrial hyperplasia? Which conservative minimally invasive procedure? It can be called as a minimally invasive procedure which is completely contraindicated. Endometrial ablation. Okay, endometrial ablation is contraindicated for endometrial hyperplasia. Remember that. The reasons also are given in the textbook. Incomplete regression can happen and addition interferes with histological surveillance. This histological surveillance becomes very important whenever you do a conservative or medical management. That follow-up becomes a hindrance because of addition. So ablation is something contraindicated in case of hyperplasia. Next. So follow-up advice of endometrial hyperplasia without atypia. So hysterectomy without atypia, you generally go with a LNG or medical management, but certain conditions you directly offer them hysterectomy also. So when then repeat biopsy says atypical hyperplasia or there is no histological regression of hyperplasia despite LNG or progesterone she has used for 1 year, so that there is no disease regression or there is a disease progression or there is a symptomatic or she is not willing for a follow-up, better to go with hysterectomy even if it is atypia. All this you will have to document in your notes. Next. Another scenario, para 2 living to heavy menstrual bleeding. Here what was there, she had a pap smear which said negative for intraepithelial lesion but plenty of inflammatory cells were there. Okay, plenty of inflammatory cells. She had a DNC. She was having a histopathology of hyperplasia without atypia. She was started on Cevista or meloxifene, non-steroidal, non-hormonal uh, medications for 60 milligrams BD. She had partial response for 3 months, but after that she came back with heavy menstrual bleeding. Just because she had all this investigation 3 months before, she was only subjected for a repeat scan, which said 12 thick endometrium. She was labeled as failed medical management, and hysterectomy was done for her laparoscopically. But surprisingly, the histopathology said squamous cell carcinoma of the cervix grade 2 with polypoidal endometrium. So, where did we falter? Why did this happen? Is it so difficult to make a diagnosis of malignancy, cervical cancer? So here, see, if you closely see, there was plenty of inflammatory cells. So the authenticity of negative for intraepithelial lesion in this case is a question mark. So this is one of the limitation of the conventional pap smear over liquid-based cytology. So we shouldn't have given lot of importance, or we could have treated her and then gone for a repeat pap. And Cevista, this is only FDA approved in India. No other country is using ormeloxifene for abnormal uterine bleeding, and only it is recommended only when the abnormal uterine bleeding where hormonal treatment is contraindicated, only in such cases, but not in cases of hyperplasia. Remember, for hyperplasia it is only progestin, LNG or progestin. No other drug is safe. So should we find fault for using Cevista, or should we find fault ourselves for not giving importance to this pap smear false negativity, false negative? Okay, this was a learning in this particular case. Next. So this is another thing we keep asking. You can take a screenshot. Previous slide. Yeah. How progestin? We are talking so much about progestin. This is what we ask you in the exam. Just take a screenshot, because time is like it's like more than 8. So these are the these are the mechanism of action of how progestin helps in reversing the pathology of hyperplasia. But remember one thing, just now I have told you, unresponsive to progestin, not failed progestin. Whenever there is thin endometrium, progestin does not work. It is not failure, it is thin endometrium. So endometrium should be primed by estrogen. Unless there is estrogen, progesterone does not work. So endometrium should be primed first with estrogen and then give progestin. So this is what you have to learn from a thin endometrium management. Next. Next, please. So this is the gist of all the drugs I have put, how they act and what are the, because medical management is one thing. So I'm not going to read out on this, but only one point I would like to say is whenever you're putting them on combined oral contraceptive pill, COCs, as a management, newer progestins are said to be more thrombogenic. than the older generation. So be careful when you are giving the newer generation preparations, because they are said to be more thrombogenic. So take a detailed history of thromboembolism risk. Assess the risk before you give a combined OC pill. That's one thing I wanted to tell in this slide. Next. So this is AUBC positive screen. There is a good list how to suspect coagulopathy. So it says high heavy menstrual bleeding since menarche, or any one of these, or any two of them. So it's again history taking which helps, and then you go with the extensive screening. So screening, history taking screening is 90% sensitive. Next. So this is the workup for a AUBC. This is the workup. Don't forget to take a consultation with a hematologist. Next. Next. Ovulatory. So we here, this is the mostly ovulatory kind of AUB is managed medically, not surgically. Most of the time it is the medical management. Yeah, next. So somebody can quickly answer what is negative progestin withdrawal bleed is seen in? You give progestin, there is no bleed. In which conditions do you see this negative progestin withdrawal bleed?
Thin endometrium.
Thin endometrium, very good. And then pregnancy. Okay, pregnancy you don't get. You give progestin, they don't get. One is pregnancy, as you said, thin endometrium. Third is Asherman syndrome. Okay, Asherman's. Yeah. Okay, we'll not go to these two questions. You will, I don't know, progesterone. Okay, we'll just skip these questions. Yeah. So here what I wanted to tell is it is continuous progestin therapy is recommended. It is not cyclical, especially when there is a hyperplasia. Please remember it is always continuous therapy, not cyclical. Here I was trying to describe what happens with an unopposed estrogen. Vascular fragile endometrium with scant stroma, gland to gland appearance will be there. Hyperplasia is the first thing which happens because of the unopposed estrogen, followed by atypical adenomatous hyperplasia, and the last stage is adenocarcinoma. So how fast this progression happen, we have no idea. That's why hyperplasia, they are insisting that we should go with continuous progestin. We should go with a follow-up biopsy for the reversal. Okay, that's the one thing I wanted to tell here. Next. E, the reasons are endometritis, postpartum, post-abortal, chlamydia, pelvic tuberculosis, and PID are the causes for the E category. I, as I already discussed, it is medication. In the N, now we have isthmocene. So most of the N category, it is always the medical management, and we have uterine artery centers which can manage AV malformation. They go with uterine artery embolization. Next. Here, what has happened? She is a 41 years lady. She presented with frequent cycles. She is not sexually active. So when they are not sexually active, they do not present postcoital bleeding. They only say they have frequent cycles. And then she never had any cancer cervix screening or vaccination because she was in periods. Perspeculum and PV are deferred due to bleeding. And then because the ultrasound said it is only 7 mm, it was thought as AUBE, and she was given progestin. But 10 days later, she again came back with heavy menstrual bleeding, soakage of bed linen. Next. So ultimately, when she came next time, upper speculum was done and there was a large exophytic growth on the cervix. So that's why I'm telling you, in the history, please highlight these factors for age of marriage, first intercourse less than 18 years, first childbirth less than 18 years, lack of screening and primary, include this in your history. That was I was trying to tell. And I really wonder why we don't do a perspeculum and PV when somebody is menstruating. Should we really differ? I don't know. By just differing, what happened? She has lost some more time, and then she had come with a growth. I really wonder whether we should not do a perspeculum or a PV when they are bleeding. It's a discomfort, but definitely I think we'll have to do. Next. So irregular, these are the different patterns we all know how a case of cancer cervix presents with. Next. Next. Yeah, these are the recommendations for the coin group, the non-structural, mainly medical. If you can see, mostly medical, and one is endometrial ablation. Okay, so regular heavy cycles with premenstrual molimina is suggestive of which type of AUB? She has regular cycles and she's experiencing premenstrual bloating, breast tenderness, all that.
Mm.
It's suggestive of.
Ovulatory.
Yes, this is ovulatory, this is non-ovulatory. So that's what I want to say, that history is very important to understand whether it is ovulatory or non-ovulatory. So I'm insisting again and again on the history. Next, please. What is the cause of sudden deviation in the menstrual pattern? Sudden deviation. All the time she was getting regularly. This time, suddenly, there is a change in the pattern. It is mostly pregnancy. Okay, so this is, I'm not going to read out this, but be aware that whenever we are asking for imaging, ask your sonologist to describe the B features. Next, the M features. These are the rule 1 and rule 2. What is rule 3? Rule 3 is when the ultrasound features are not fitting into 1 and 2, or it has a mixture of both 1 and 2. Simple. Does not have 1 and 2 features, or it has a mixture of both 1 and 2 is rule 3. Next. So iron deficiency anemia, the blood loss, we said more than 80 ml. When the blood loss is more than 80 ml, in one cycle she is going to use 35 milligram of iron. And one more thing I wanted to say, in pregnancy we say less than 7 grams is severe, isn't it? But here we take in a non-pregnant condition, not 7, it is 8 grams. This is one difference I wanted to tell. Next. This is a detailed management, medical and surgical table giving all the conditions, palm and the coin, and the management. This side is the medical and this side is the surgical. Next. And these are the last two slides. So my final message is, please concentrate on the pattern of bleeding. As per the new recommendation, it is divided into cyclical, acyclical, heavy and intermenstrual. Always AUB under palm coin. Always compare with her previous cycle. Whatever she writes, you please document that. Intermenstrual is frequently complained as frequent cycles. They don't say intermenstrual, they always present as a frequent cycle. Postcoital bleeding is complained of only when she is sexually active. Per speculum examination, I feel it should not be deferred during menstrual cycle. Only it should be deferred when you're taking a PAP or it's a case of sexual assault during periods. We write she's in cycle, that's why we are not taking the sample. And then hysteroscopy, because there is a difficulty in visualization, HSZ. These are the conditions I think where we should differ, because we missed out on a diagnosis of cancer cervix. Both see and feel the cervix. We always feel for the uterus, but feeling for the cervix is equally important. Approach to AUB, two things always to be missed out. In our experience, we have missed out couple of 3-4 cases of malignancy, including choriocarcinoma. So, ruling out pregnancy, HST to be included in our workup. And then, whenever you have an positive family history, please highlight it. And because these are type 2 are poor prognosis type of cancers. Whenever you encounter that atypia or hyperplasia with atypia is given in your biopsy, don't hesitate to send it for immunohistochemistry. Next. Yeah. So in AUB, we'll have to turn off the tap, that is the bleeding, and fill the tank, that is with iron. Non-hormonal is the first line before the evaluation. After evaluation only, that is again I'm telling, rule out pregnancy, rule out malignancy, then start hormonal. If it is thin endometrium, defer endometrial biopsy. Think of giving estrogen and then the progesterone. If it is more than 12 and there are risk factors, I'm again telling, please assess for the risk factors for endometrial cancer. Consider ET even if the thickness is 5 to 12 Choose the right dose of progesterone. Hemostatic, we know why it is hemostatic, because 10% of the progesterone is converted to ethinyl estradiol. So combined pathologies can be there. In one case, we have seen cervical cancer with multiple polyps in the uterus, who was managed on Cevista. So benign and malignancy can be there as combined. Don't miss out on that. Think of office procedures, easy to do. People office hysteroscopy with 2 scopes, and proceed with a complete EB whenever there is a risk factor for endometrial cancer. I think these are the learning points in my 30 years of experience. Thanks for bearing me for such a long time. Yeah, thank you, Vijaya.
What should I
Thank you.
say? Awestruck. That should be the word. So good and so simple and so much of simple questions and answer, which is usually the PG struggle to answer in the exam. And that shows how much experience Malti ma'am has. I'm sure all the PGs are really lucky to listen to ma'am. And I don't know how 2.5 hours time flies like that. Malti, you're really awesome. I just want to have more and more classes in future, if at all I'm continuing this. And so that whatever you have, you should tell all the PGs. That's what my idea is. Thank you so much, Malti. Thanks a lot.
Thank you. Good night, and thank you so much for the opportunity and the patience you all had to wait for such a long time.
Yeah, yeah.
Yes, thank you very much. Thank you very much, madam. It's really because the whole concept is such a basic topic. We really can't afford to make any mistakes in them. And you have touched the concept, they've taught everything so conceptually. So that is very important. Many people, they just try to understand all hi-fi advanced stuff. But this AUB is such a grassroots level topic for us, and we really can't afford to make any mistakes in this because it's such an important and common one. And we see day in and day out in clinical practice. Thank you so much, madam. Thank you. It has been really an awesome journey for us this last 12 months conducting this Aksharam series. We started off with Dr. Suresh talking about FGR. We had Dr. Aparna from AMC, Dr. Girija Wag, we had Dr. Jayanti, we had Dr. From CMC Velo, Dr. Lily Varghese. Lot of people, all the stalwarts in teaching were with us for this 12 months. And it was an amazing journey for me also to keep in touch with all the professors, teachers. And I also had a lot of learning. And I just felt, learning never ends. And, sometimes I take notes and just take screenshots of all the things. And sometimes when PGs ask me, madam, when will we get the final compilation of all the 12 classes? I will tell when the class is over, we will just send it to you as a YouTube link. And it's going to be useful for everybody. Everybody. I mean, the clinicians, however experienced we are. And thank you so much, Malti madam, for this excellent class on abnormal uterine bleeding. And thank you, Vijaya madam and Geeta Lakshmi madam, for the opportunity that has been given to me to actually take this Aksharam series forward and do it for the past 12 months. I'm sure we are going to miss this, but definitely we'll be coming up with something in the next with the presidential tenure of Sampath Kumari madam, something teaching like this. So thank you so much. And million thanks to Sheel, Sahiti, Chitrakala for the opportunity, because you have given us a beautiful platform, and we hassle-free, no technical hitches, nothing. It was a
Don't
smooth
worry,
sailing.
Karpagam, we are planning to continue, so we'll do it. No problem.
So we will definitely have educational programs on and off. And thank you for Vijaya Madam and Geeta Lakshmi Madam for making me a part of this program. Malti Madam, thank you so much for the excellent class.
Malvi.
Thank you. Thank you.
Thank you so much.
But share the link so that I will listen to your topics.
Yes, I will do it, Malvi. I have. I'll do
Yeah.
it. Okay.
Thank you.
Thank you.
Thank you, madam.
Thank you and good night.
Thank you.
Thank you. Thank
Uh,
you.